thanks everybody for coming and supporting this. And we want to thank Body Vision Medical for putting out the financial support for this. So what we'll do is we're going to talk a little bit about the technology, and then I'm going to talk about my experience with the technology, which I've at the Cleveland Clinic, which I've had for many years. My history with this company goes back 5 or 6 years when it was. I mean, we helped them kind of develop. They dropped the system. We told them what we liked and much of what we didn't like, and then they went back to Israel and they did some coding, and they came back to us with something else, and we tell them we liked it or we hated it, and it was a really cool process to see how this works, and to the point where they have I think really great and robust system right now, which we'll talk about. This is a redundant slide. If you're an advanced bronchoscopist interventional pulmonologist, we all know that CT to body divergence exists both in EMN and in shape sensing, right? And if anybody was at the talk this morning, we talked about the reasons that this happens, but the product of this is a lack of a tool and lesion confirmation, right? So the technology is designed to get you to the nodule, to biopsy the nodule. Okay, everything else after that is up for grabs, because there's things that you can't control in that environment. You can't control the cytology reading. You can't control the performance of the tool, so on and so forth. So it's become very apparent over the years that in order to get at least the most optimal performance of your technology is to get something into that nodule to do the biopsy. So the concept of tool and lesion has really become in vogue over the past year or two, because if you could do exactly what the interventional radiologists do when they do their TTNAs, right, is you ensure that the biopsy tool is in the nodule, therefore you're going to get the tissue that's there. Okay, and that's exactly what they do with their CT guided biopsies. They don't put a needle in and hope they find the thing and get into the area. So unfortunately, the tools that we have now, needles and brushes, this is a game of precision. It's not a game of hand grenades. So here is our the robot data. And some E&B data over the course of the years, and you could see that reported diagnostic yield, and for good or for bad, is okay, but it's not great. And we talked this morning about the things you could do to enhance your robotic performance, but that comes at the expense of bringing in advanced imaging, which is costly if you don't have it already. Real-time imaging, we could call it real-time intraoperative imaging, is really key to improving outcomes. Again, if you were at the talk this morning, you saw that you could enhance outcomes by maybe 15 or 20% just by adding intraoperative imaging to your procedure. The imaging not only allows you to overcome CT body divergence, but also gives you the confidence that your needle is going in the exact spot. We could always navigate out to a potential lesion, all right, or the lesion that the virtual target, but you don't know if for instance, your needle throw is going through and beyond it. You don't know if your needle throw is going into it and deflecting off the side. So with real-time imaging, you could see that the needle or whatever biopsy tool you have is right inside that lesion, and it makes you feel comfortable that at least what you set out to do is being accomplished. So what is lung vision? So lung vision really is sort of driven by this thing called AI-driven intraoperative imaging, and it delivers very near CBCT quality intraoperative 3D images that you could get with any C-arm. So the 3D imaging that you could historically gotten with your cone beam or even your portable cone beam, you could now get from your little crappy 2D fluoro that you borrowed from the ortho suite that put it in a corner because it went out of, they don't even use that one anymore for the past 10 years. So any 2D fluoro that's digital, you could get great imaging from, and I'll show you some examples in a second. And the other thing about it is that you could use it the system standalone, just with a regular plastic catheter, or you could combine it with a hybrid scope. You could combine it with a robotic scope, and it could really give you the imaging that I think you need to have a successful navigation. So how does lung vision work? Well, in a nutshell, what lung vision does is it takes your C-arm, you'll do a fluoroscopic sweep, and then it'll take that imaging and reconstruct it using their algorithm to give you these kind of images, okay? Where you could get imaging that looks very close to what your preoperative CT is. Not only does it give you great imaging, but it allows you to recenter where your nodule is in space. It allows you to do augmented fluoroscopy, so when you tap your fluoro, you know where your nodule is and you know your target is, and not just in AP. You could once you've updated your location, you could take your C-arm and put it into LAO 30, you could put it into RAO 40, and that nodule will kind of move wherever you go with it, okay? And also gives you this interactive 3D view, which is which is something that you could see on a lot. If you've done any cone beam cases in a room, this is a nice, similar view to what you get. Not only do you get on the augmented fluoro the nodule itself, but you also get a representative pathway, which isn't always perfect because pathways move and airways move during the procedure, but at least it gives you an idea of where you need to bring your catheter. And as we talked about, intraoperative imaging, whether you're doing it with a fixed cone beam system or whether you're doing it with a mobile system, has improved yield, and it's improved yield, I think, significantly. I think when you look at your studies, it's going to be somewhere between 10 and 20%. It's really going to enhance that. And why wouldn't it? You're overcoming CT body divergence, and you're trying to achieve a tool and lesion type of biopsy. So you're biopsying exactly what you set out to do. So yeah, the evolution of lung vision, what they don't see here is all the aggravation that the end user had to have as we went through this. But it was important that aggravation gets transformed into meaningful information to the company such that they go back and they make the product and the user interface better. So at the very beginning, it was just augmented fluoro. And then as time went on, the company created AI-TOMO, which is this 3D modeling, and ultimately we got tool and lesion type spins. Here's a typical example of the imaging that you can get. If you look at the CT image on the left and the lung vision rendered imaging that you get on the right panel, it's pretty equivalent, okay? Again, over here, part solid lesion, and the equivalent over here on the right. I mean, and these are small nodules. These aren't big nodules at all. So the reconstruction that you're getting off the 2D fluoro is pretty astounding, if you ask me. I mean, this is really great imaging. More. You could just see this preoperative CT on the left, and then you could see the corresponding lung vision imaging on the right. This is almost a pure ground glass on the left, on the right panel, on the left upper lobe, and then you could see the imaging that you're getting off just a regular 2D fluoro on the right. Again, the other thing that you get with this is the augmented fluoro. So you have a target that you're driving towards. And you always see the target that you're driving towards it live. So you're extending out your catheter, your foot is on the pedal, and you're driving the catheter out to that target. I think is pretty powerful. And not only can once I drive out to the target, yeah, that's AP, but if I move into RAO or LAO and I see that divergence, right, between nodule and catheters here, but if I look at it from this standpoint, catheters in front of nodule, you know that you're not in the right spot. And it saves time from doing a full cone beam sweep. You just know you're not there, you reset. Yeah, Otis, sure.
What's the difference between CABT and AI-TOMO?
What AI-TOMO does is it cleans up the CABT image to give you more defined borders of your nodule. That's all it really does. It learns over time what the nodule is and learns what the rest of the stuff in the background is, is not nodule. And it filters those away and it brings out the nodule itself. Sean, why don't you come up, talk about, we have Sean and Nina here. Sean is in Minneapolis and Nina is in a bunch of places outside of Philadelphia. But Nina is where Nina is, right? And they're going to tell you about their experiences. No, you'll understand when Nina gets up here to speak. They'll tell you about their experiences, why they got the lung vision, how it performed once they got it, and then I'll take it from there about the Cleveland Clinic experience.
Thank you, Joe. Yeah, I'm Sean Stoy with North Memorial Health Systems. I'm actually an independent group that works out of North Memorial called the Respiratory Consultants. I did my interventional training at University of Chicago, graduating 2017. Disclosures, I am a consultant for Body Vision. This is also not a CME discussion anyway. So just a little bit of my practice. It's a mixed critical care, outpatient, inpatient, pulmonary interventional practice. I have plenty of critical care duties, and on top of that, I have an interventional practice that I share with one other bronchoscopist. Is this reverbing a lot?
You good? Oh, you're reverbing.
Yeah. Can we fix that? Okay. All right. So we have two advanced bronchoscopists, myself and a non-formally IP-trained advanced bronchoscopist who went through more of a traditional pathway. And then we have one medical assistant who acts as a part-time coordinator for a lung nodule program. So we get a half-day nodule clinic a week. We get one procedural day a week. What I'm trying to explain is I'm in a community practice. I don't have fellows. I don't have research coordinators. I have one half of an MA to help with this. And so in order to build a practice, you have to think of other things to demonstrate to the hospital what your needs are. The hospital system I work for is called North Memorial Health, or work with is North Memorial Health. It's a level 1 trauma center, it's 350 beds, community satellite hospital as well. So 2 hospitals total and about 25 clinics. It is in a combination of an inner city population and a suburban population. The pair mix skews Medicare, Medicaid. The catchment area is probably about 750,000 people with multiple competing health systems in it. In 2017, I joined the practice. Very end of 2017, I joined the practice. Super D was in place. They'd had that in place since, I think, 2012. In 2018, we hired a second critical care / officially IP-trained provider, so we had 3 total advanced bronchoscopists at that time. In the middle of COVID, one of our advanced bronchoscopists left, or actually he was one of our IP doctors. He actually called me up one day and he said, I hate doing this. And I said, well, you shouldn't do it anymore. So he left to do pure critical care. No hard feelings to him, but if you don't like what you're doing, you shouldn't keep doing it. And that's part of what building a program, especially a community program, is you have to be passionate about this. You can't just want to have tools. You have to be working with patients. In 2021, we acquired Lung Vision, and it quickly became our navigational platform. The reason that we changed from SuperDimension to Lung Vision was, I will admit, when I started practice, I was trying to get a robot straight away. Monarch was the robot on the market. Everybody was trying to get a robot. Our hospital wasn't having it. Our hospital is a community hospital that's very much averse to anything that rhymes with capital. We already have a system in place. And so, we used Super D and eventually was getting at the yields we were supposed to be getting with it, but became very frustrated about that generation of technology and chasing, right, the ubiquitous green ball as opposed to the actual nodule. And I had worked with Body Vision in my interventional fellowship and discussed with them, and we were able to place a Body Vision system without nearly as much need for capital, and we came up with an agreement that was actually able to get new technology to continue building. And why Lung Vision on top of that? Again, SuperDimension had their Illumicite as well at the time. But having used Body Vision in the past, and what I was missing on my from virtual virtual targets is when I'm getting to the target, but I'm not at the lesion, why is it? I want to know whether or not I should be even trying to get there. So with lung vision, having real-time augmented fluoro and real-time, essentially CT imaging, where am I in relation to the target? How much time should I be wasting on it? Because if anybody's has done navigation bronchs, it gets very frustrating when you're just getting nothing on either your radial signal or you're not getting diagnosis. How much time should I be spending on these patients? Can I get there or can I not? And again, because of that, my yields, I don't have the data because we lost the person that was going to look at it, but my yields are at where they should be, just anecdotally. But in terms of how much time am I spending chasing after lesions that without articulation, without additional technologies, how much time am I wasting going after them? Seeing that I'm not there, moving on, getting the rest of their staging done with the patient, deciding whether or not they need to go for TTNA. Our procedure times are down. And it's cost per case is important for my hospital. Again, I don't work for a university system, and even they're important for university systems. Joe can attest to that. But cost per case matters. So how much does the equipment cost you to get an equivalent yield? And then lastly, with lung vision, I could already see the future with it, meaning it's adaptable. It uses whatever technology you currently have. We didn't have to purchase anything new with capital. And then as we can purchase things down the line, you can continue to use it, as Joe talked about. And ease of use, shallow learning curve, yes, but there's definitely a learning curve, especially if you're used to other forms of navigation bronchoscopy. The way you navigate with lung vision is different. You're not chasing a sunset sign or a green ball if you're used to super dimension. So since I started, I joined in 2017 in December. So we'll just count 2017 as prior to me starting. They had done 13 navigation bronchs. In 2018, we did hire another IP. We did 27. In 2019, pre-COVID, we did 63, so we're having good growth. In 2020, I think most people experienced a plateau or a drop as COVID really impacted things, and we lost another IP provider, and a lot of us were just doing a lot more critical care. 2021 is when we acquired Body Vision. We were able to do 81 cases. Last year we did 97, and then this year to date we've done 87, putting us on track to do 140 cases this year. So we have been able to grow a program using Body Vision, and part of the questions is, what changed? Our nodule clinic program hasn't changed. We're still a half-day clinic a week. Our referral base hasn't changed. I think what has changed is with Body Vision, I'm more confident to be able to tell patients accurately, I'm never afraid to go after a nodule. And participating in tumor conference, when people ask, can you go after this? I always say yes, I can go after it, and then I try to be honest with how likely I'm going to be able to get it. But with Body Vision, again, I know when I'm there whether or not I can get it. So I'm more confident telling patients, let's go ahead and try. And if we can get there, we can. If we can't, we can't. If we can get close, we can drop a fiducial. And we quickly will know that we're there. So I was able to use Body Vision to take the same group of patients and grow the number of procedures that we're doing. And in relation to that, I'm also getting more direct referrals. There are other hospital systems in town that have started sending me patients that didn't have navigation bronch, and also directly getting referrals from the cancer center on a more regular basis as we presented these cases in tumor board. So one point that I want to make is, Body Vision is a tool that we can use. Part of the other thing that I've done in our practice, and I think all of us try to do in a way that I try to differentiate us from interventional radiology, is we're taking care of a patient. We're pulmonologists. I spend a lot of time going through with patients why they have a nodule, and when they have cancer, what their next steps are. In general, interventional radiology is not doing that, and my patient feedback in the cancer center is seeing that. And so, use whatever tools you have, but also continue to be a pulmonologist and not just an interventionalist. So again, our procedural volume, we're on pace to do 140 this year. It's a 44% growth since last year. Year-over-year growth has been about 48%. Our hospital system calculated last year, or earlier this year, I want to say, what our contribution margin was. And on average, our cases are earning $5,000 per case, which I think is on par with what could be expected nationally for the value in a case. So everybody was surprised. They all expected us to be losing money, as most people expect us to either break even or lose money on bronchs, and we make it up in the back end on downstream revenue. They were surprised to find out that $5,000 per case is not nothing. So 140 cases to a community hospital, an extra $700,000 matters. So then with that in place, and after having used Body Vision for 2 years, they saw the value, they saw the growth, and I came back and said, okay, I feel like I've reached the peaks of what I can do with the current technology that Body Vision has. Can we please reconsider getting a robot? And we were actually able to work out an agreement with ION to get a robot, which we placed in May 17th of this year. Since then, we've done 37 cases, 2 of which were yesterday, so I updated it for that. We're using ION and lung vision together, as was shown. So ION to get out towards the lesion, lung vision, live fluoro navigation, spin the lesion if we need to, confirm radial in lesion, and then tool in lesion on fluoronav. The first 37 cases, our diagnostic yield was 94.5% with an average nodule size of 15 millimeters, between 6 and 47. People can ask, why do you use navigation for a 47 millimeter mass? One, because you're trying to learn the technology and any experience is good experience, and 2, if anybody's tried to biopsy a large heterogeneous mass, they are oftentimes necrotic. So to be able to actually selectively choose where in the mass you biopsy is important. The nodule characteristics, 80% solid, 10% semi-solid in GGO. The 2 non-diagnostic cases, one was a 7 millimeter nodule, one was an 8 millimeter nodule. Both of them had lymph nodes with granulomas, and are presumed that these nodules are actually granulomatous. They're now obviously in surveillance at this point, with no plans to do a TTNA until they show any changes. So in summary, lung vision has been a good tool for me to be able to build around. I've been able to continue to grow my program and been able to show the value to the hospital to acquire more advanced technologies with it, while continuing to use this to maximize my yields with new technologies. And my last thing is, again, just remember that you're not just a proceduralist. Part of building your program is to actually take care of the patients. So, thank you.
All right. Thanks, Sean. So let me introduce Dr. Nina, as people refer to her as. And she's going to talk to you about her slightly different but similar experience out in the main line, right? Come on. All right,
Sounds
good.
Thank you. Hi, everybody. I'm going to try to make it short and sweet for the sake of time. So instead of diving into the first few slides, I'm going to go a little faster. So my model actually is different than the 2 previous models that were presented to you. The first one was purely academic. The second one was a mixed, where the actual hospital owns the machinery, and you have to go through capital budgeting to be able to obtain the actual equipment. I decided to just jump off the bridge and actually own pretty much everything. The private practice that we have is purely interventional pulmonology practice, where we offer a turnkey model. And I'm going to go through these slides really quickly until we get to the nitty and gritty of the presentation. So when I presented the model to the hospitals originally, they were very hesitant because they wanted to own the equipment. They wanted to decide exactly what goes where. Long story short, we offered them a turnkey service with access to tertiary level care without having to leave the community, which means their patients were definitely not going to be migrating downtown. I am localized right outside of Philadelphia. Sorry, I didn't start with that, in the suburbs. And we are right in Montgomery County and surrounded by 3 major healthcare systems: Lehigh Valley, now Jefferson, that swallowed pretty much Abington and the Einstein system, and we have the Doylestown Hospital. So, and we are approximately 45 minutes from University of Pennsylvania And the hospitals that are in the city, although accessible geographically, the majority of the patients are extremely challenged in finding the time, the finance to be able to actually go down for daily radiations, daily treatments, et cetera, which is the story of everything between Pennsylvania and east of California. So what we decided to do is to really bring them the technology and be able to be diagnosed and collaborate with thoracic surgery if they're not local, that come from tertiary centers in these small hospitals and ultimately are able to deliver the care that is needed locally. What we tried to do, and we were successful until COVID hit, is to deliver a diagnosis within 7 days. By the time the primary care physicians identify the lesion, they are referred, and within 24 hours they are seen. Hopefully they are on the OR table within 3 to 5 days, and ultimately seeing the oncologist with pathology cooperating, able to give us a diagnosis, and they will start their radiation ultimately within a week to 10 days. We were able to achieve that in 95% of our cases, and we were able to also prove to the hospitals that they do not need to break the bank to ultimately be able to deliver the care that is needed. So we give them a package of bringing in the machines, taking care of the patients, identifying the patients ahead of time, but also analyzing the quantitative and qualitative data that the hospital needs. From the efficiency standpoints, they are able to pay our practice without having to invest through capital budgeting and invest $500,000 in equipment. But we are also able to do that without, knock on wood, complications. I mean, our pneumothoraces and our post-intervention hospitalization rate is less than 5%. So what ended up happening is, with the collaboration in a collaboration with the industry, we were able to bring the latest technologies. These are numbers that ultimately allowed us to have a stage shift using old technology, but we were not able to increase the amount of cases because COVID happened, but also the turnaround in placement of different pieces of equipment in the OR. Getting the local staff trained has proved its challenges, and ideally in our model we should have 10 minutes to 15 minutes turnaround time between the cases to optimally achieve at least 6 cases a day, and we are in the OR 3 days a week, and our goal is to ultimately hit at least 500 if not 600 cases a year. So what we were able to do by bringing in Body Vision is once the setup is done, really the patient just needs to be on the table without having anything on their body. Just they're set, they're prepped, intubated, and then we kept track of the time in the room, scope in, scope out, and on average, our cases are 20 minutes, scope in and scope out, and within the room, they're 35 minutes in the room, and they actually are able to turn around the room pretty quickly. So these are the numbers in one of the centers, 2 centers. We cover 3 different hospitals at this point. And when you look at the numbers in 2021, that was before we were able to actually get the Body Vision in place. The numbers in 2022, the Body Vision allowed us to increase our interventions by obviously 110%, by 34% in totality. We do have the therapeutics, which are not really concerning us in this presentation. With the increase in cases and the ability to really adjust the operation within the operating room and the workflow, we were able to complete a totality of 384 cases. And it was just interesting to see the actual referral pattern in here. The hospital-owned practices referred only 35% of the cases. The majority of the cases were referred by independent practices that to whom we did educational seminars, and we had an outreach using the technology that we have in these hospitals. So we proved to them how the navigational bronchoscopies, the Body Vision, was actually allowing us to be able to get to their lesions precisely and effectively. That increased the downstream revenue. And the most important part for the hospitals is that the Body Vision was actually the lowest cost per case when you compare the Body Vision system to the other ones. An average cost for the actual systems as far as tools and anything else that we are using intraoperatively from the disposable standpoint was anywhere between $2,200 to $3,000 per case. But using the Body Vision, we were able to achieve actually a average cost of $1,100, and that's a significant saving when you add it up, when you're going above 200 cases a year. The yield also improved with the Body Vision, and that the anecdote in there, the on-site rows variation depends on your cytologist and pathologist, and that's a whole other talk. It is absolutely crucial to have the right person in the room, so you do not have to send the actual specimens to another center or another or for a second opinion, because the slides, the positivity obviously has improved after review of the slides, knowing that you are in the lesion when you do your Body Vision biopsy. It's you can actually reset the system while you're doing it and have a full visualization of where you are as you're actually doing the biopsy. So financially, it has been absolutely more efficient. And clinically, it has been more effective without delay in referral. Overall, in one of the centers, we had over 116,000 savings with regards to equipments in the IP cases, and the medical oncologists and radiation oncologists are extremely happy, specifically the radiation oncologists, because their cases have increased significantly since we've established the Body Vision system in our program. It was short, sweet. I'll take any questions later on, but thank you.
So Nina, just clarify for us real quick. Do you have systems at each of the hospitals you're at? Okay.
Yes, I do. So the Body Vision right now was initiated in one hospital, and we're in the process of actually, it definitely financially makes more sense. And it's more effective with regards to timing within the hospitals, because we can see that in one center, we cannot do more than 4 cases. In the Body Vision hospital and site, we can actually push it up to 7, 8 cases if we need to per day.
Okay. All right, well, let's talk about our experience at the Cleveland Clinic. We're a little bit more of a hub and spoke kind of model. So when we first got Lung Vision, it was at our main campus, right? And, you know, busy, everybody knows, busy, crazily busy place. You know, 10 interventional pulmonologists, another, 5 or 6 advanced diagnostic bronchs. But there were 5 primary users used Lung Vision. It was myself, Sonali Sethi, Francisco Almeida, Colin Gillespie, and Mike Machuzak. We worked with the first generation system. I think that mistyped. That was probably since 2018. Second gen system where we could do all the bells and whistles since 2021, and averaged about 80 navigations just using Lung Vision standalone. And then once the Monarch came, we started using it with that. And then once the Ion came, we started using it with that. And we just acquired our second system for one of our regional hospitals, and I'll talk about that and what the justification was for that in a second. So the reason we got it initially was it was a placement just for the registry trial and product development. We used it initially similar to Illumicite because we had no robots at that point. And then once the robot acquisitions happened, we were using robot, but we also, some of us used Lung Vision because sometimes it's easier to use the Lung Vision. And the reason for that is the cost savings that you're hearing about up here, which we'll talk about in a second. But we justified the purchase at the main campus to administration just by the cost savings per case. Because the cost of using Lung Vision with just a hybrid scope is zero, scope-wise. If you're using their catheter versus a robotic scope, there's still an $800-900 savings per case. So over, do the math, over 100 cases, it's a lot of cost savings for the same reimbursement. So that's how we justified it for capital at that point. And right now at the main campus, it's not used a standalone as much, but it's certainly used as a imaging adjunct to Ion and Monarch, especially and occasionally as a standalone. So as a standalone, we had clinical experience, and this hopefully will be published soon, and it was 141 patients over 2 years, and sort of in the middle, the technology sort of improved. And our average size, nodule size, about 20 millimeters, and our overall diagnostic yield was around 79%. However, if you look over time, as the technology improved and our comfort with the technology also improved, our diagnostic yield went up. And again, this is all just based on the fact that the imaging got better, the tool and lesion imaging got better, our comfort got better. So you could drive kind of high yields with this without, a traditional robotic scope. How do we case select the standalone, versus with robotics? I mean, look, for me, if the nodule was, super easy to get to, nice nodule, air bronchus sign or bronchus near it, I liked doing that, and I like doing it because it was one workflow as opposed to a robotic workflow, which is several workflows, right? A robotic workflow is you go in with your bronchoscope, clean out the airway, and then you move the bronchoscope cart away, and then you bring in your robotic stuff, and you do your robotic stuff, and then when you're done, you got to move that away, and then bring in your EBUS, right? And it just, all these workflows just extend the case time. And if anybody knows me, I'm like a stickler. I'm all about case time. Like, the faster we get done with the cases, the faster, the earlier I go home. And also the more cases you could squeeze into a day, which in Cleveland is an important thing because we just do so many cases. So, you want to go home and you want to get the cases done. And the cost savings, which we talked about. So we have all these toys at the main campus, but then we started doing bronch at one of our regional campuses. This place called Fairview Hospital. It's on the west side of Cleveland. It's literally 7 miles from the main campus, but it might as well be 3 states over because the patients don't want to drive into downtown Cleveland. I mean, I don't blame them. I don't want to drive into downtown Cleveland. This is like suburbs, western suburbs, and they're just stuck in their ways. And I'm sure many of you probably have hospitals like this or patients like this who just don't want to come to your place. So these are people that would rather get staged with a PET scan than drive downtown and get an EBUS. I mean, this is the insanity of it all. They just won't go. So we set up shop down there first with EBUS, and then as the EBUS program grew, it became very obvious and apparent that we needed a nodule technology. But the hospital's a regional hospital. They don't have the money of the main campus. They don't have this kind of capital budget. And they said, Doc, what do you need for a robotic scope? I said, well, I need $500,000 and another $500,000, or maybe $700,000-$800,000 for a comparable system to main campus, because that's what it's all about in Cleveland Clinic. We want it to be comparable wherever you are. And you need imaging, right? So you need the tech and then the imaging. It costs a lot of money. They didn't have that. They had some philanthropy money put aside, and look, the base cost of the lung vision was half the price of a robot, and the imaging's basically thrown in for free because it's doing the imaging for you, right? You don't need a separate SIOS or cone beam system. So it became really, easy for the hospital to decide to spend this capital on the money. And look, it's the same reimbursement as you would get if you're doing a robotic case, but with half the cost. These are our financials, and these are sort of hypothetical financial modeling, right? The first line is, this is all contribution margin, right? And contribution margin is a financial accounting term. Basically, for us, it's your reimbursement minus variable costs, and it's whatever's left over. It's indirect variable costs, not direct stuff, variable. So the costs include your peripherals, right? Your biopsy, your scope, your biopsy tools, right? The length of time you're in the room, things that vary from case to case. All right, and this is how you're all gauged by your administrators, by the way, on the contribution margin. This is just for Medicare reimbursement. Scenario 1, and you could see compared to robotic scopes that the average tech CM, again, you could calculate contribution margins in many different ways. This is just Medicare only, so, Sean, your contribution margin was much higher, but you might have a lot more private payers, right? But we were positive per case, and we were doubly positive versus a hypothetical robotic case, okay? The scenario 2, right, is when you're using 2 different reimbursement schemes. Now, you should be getting all APC 5155. That's your facility reimbursement. That's $6,100. National average varies from city to city based on wage index, but national average $5,100. And you'll get that if you do a lung vision with a needle and a forceps, okay? Any case, robotic case, needle, forceps. versus a reimbursement of 5154. And you can see still, if you get a lower reimbursement, so that's why I only put this up here, because you all should be making sure that your hospital billers and coders are coding for APC 5155, because once you drop it into the lower APC, it's half the reimbursement, and suddenly you're negative and they're coming at you and you're like, what are you talking about? And I should be positive. And they say, no, you're not. So know your, if anything, right? Know your data, right? Know your value. And scenario 3 is where the payer mix is mostly managed care, and managed care with maybe 150% Medicare, which is, that's a low-end number. Most of us managed care are getting 200 or 2x, 2.5x what Medicare pays. But you could see, once that happens, once you increase your payer mix to a private paying group, your average contribution margin is $4,500 per case. It makes money. It's closer to what you had, right, Sean? So, look, what we want to be careful of here is what happened with Da Vinci Robots, right? Da Vinci Robots, for robotic surgery, this is what happened. They went from a small company to a $600 billion market cap with no data. They had no data, but surgeons just started doing it. Look at the procedural volume over 10 years. It's just like crazy. And not only was there no data, it was more costly to do. So look, I just want to, you all do what you do at your own individual places, and everything is individual, and I'm by no means am I being critical of anyone in this room, but this is a warning, I think, to us, right? We need to learn a little bit from history here, because you had a robotic, surgical robotic platform that had no data attached to it, that just took off and became the predominant robotic platform in the United States. And it was no data, more costly, and that's what happened. And we have to make sure that doesn't happen in our space, because whereas it's a lot easier for hospital administrations to accept more cost in a surgical environment, it's really, they're not going to be as forgiving to us, okay? Because, our reimbursements are light years below what they get. So just look, I'm just kind of pointing that out there. So look, some of our experience is that we like this, and if you walk out of here with anything, I want you guys to know that this is a good technology. It's not great for every nodule. There's some small nodules that, the technology is just not good for, that a robot is better for. And that might be 15 or 20% of my nodules. Maybe it depends on where you are and what geographic region you live in, and so on and so forth. But for 80% of the nodules, it's a really great technology with super high yields, and it tells you everything you need to know. It gets you there, it gives you a tool and lesion, and it makes your procedure go fast. And that, to me, those are all kind of wins. And it's done at a lower cost with the same reimbursement, and hospital administrators like that kind of thing. So I know we're all addicted to technology, and it's super sexy. Having a robot is wonderfully sexy. But if you guys know anything or learn anything from this, is that robotics are great, but they're not that great without imaging and image guidance. And only 15% of hospitals in this country who have a bronch robot have imaging capability like that, either a cone beam or a portable cone beam. So even if you have a robot, you should be thinking of using this if you don't have advanced imaging, because this could give it to you. And, you could reduce your cost overall, because you're going to reduce your your finances with the system. So I'll leave it at that. We have a couple minutes. If you guys want to ask questions, go right ahead. All right? Good. Thanks. Cleveland skyline, I think. Any questions? Yep. Can you maybe, we just go to the mic over here. Mic's right here, right here.
The portable cone beam CT and the lung vision, it's pretty much the same cost. We would like to get some sort of imaging, but when I looked at it, the portable cone beam CT and the lung vision is not a whole lot different. One is 220,000 or something. The other one is 300,000. It's not a whole lot different.
Yeah, but what portable CT doesn't give you? It doesn't give you augmented fluoro.
That is true. Okay.
Right? So here's the thing with that, right? You could go out to a lesion, right? You get there, you do a spin, and it says, you're 10 millimeters to the side. Now what do? You pull it back, and which direction do you go? Any idea? I don't know. Maybe I need to go superiorly, so I'm going to maybe do that. Then I do another spin. Am I there? No. Right? Here, you always have an augmented, just like, the people who use cone beams in this room, you always have a target to navigate to. So you could totally see with lung vision that you're off to the side. I don't need a full spin to do that, which again, it cuts down on procedure time. I know when I get out to end navigation, right, and I look to see where my catheter articulates, I do a shot in AP, and I move it, and if I'm right on, and I move it to LAO 30, and I'm still right on, I'm there, I'm done. But if I'm in it in AP and I move it to the side and it diverges, I'm not there. I don't have to do a full spin to know that, right? So, I come back, I re-navigate, I go into obliques, and you'll see that the more you use of this, the more you'll get out of the AP world, and more. And by the way, AP really only works in two areas of the lung: lateral segment of the lower lobes, and maybe some apical segments. Everything else is best done in oblique planes. So, so that's what portables don't give you. And if you're getting a price on a Sios for 250, 200,000, I want to talk to your rep.
What about, no, that 300,000, I think that's what I heard.
Okay.
The other thing is, how much time does it add to this add along with the robotic bronchoscopy?
I think it reduces the time of your robotic bronchoscopy, because even if you have integrated Sios to your ion, that spin takes the setup and the spin. And look, I do integrated Sios ion cases, but that spin takes really long to set it up, do the spin. And there, again, you don't get augmented fluoro. You get a little iceberg view, which is great. But we've noticed that the nodule could still move intra case. We'll do a redo registration, right? Lesion registration. It'll be here. 10 minutes later, it's down here. So it's hard to do that with pseudo virtual technologies. So I think it cuts down. Me personally, I don't like the Sios integration because it takes too long, and it doesn't give me the information that I think I need to do the case accurately. But not just me.
I concur.
Do you guys? I don't know. If
I
you have
concur, absolutely.
Okay.
I mean, it's extremely fast. You don't have as much radiation. You definitely, the lesions do move intraoperatively, sometimes significantly. It depends who your anesthesiologist is, with the volumes, multiple factors, but you actually have a live image right there and then. And I can tell you, the fastest case, I was able to go in and out 10 minutes.
Time is money, guys. Your contribution margin is going to be affected by the time in your room. If you're doing a 3.5-hour robot EBUS case, versus a 2-hour, robot lung vision, EBUS case, that's a huge difference in terms of cost. And your contribution margin will look so much better. It's because you're just using less OR. OR time costs money. Nurse time costs money. Tech time costs money. So you have to think of these. You have to think of these things. Everyone's got to stop thinking about, your professional reimbursement. That's it's fixed. It's going down. That's not what we should be getting paid on. We should be getting paid on value that you bring to the hospital, which is facility reimbursement. That's how surgeons get paid. I have a surgeon right here. That's how they get away with the freaking salaries that they get paid, because they're bringing in all this money to the hospital on the facility side.
Or use my model, and you'll get the facility side.
You got a
too.
question?
Yeah, I've heard that based on the location of the nodule, that the setup might vary or the spin might vary. Could you guys speak first to the challenge of setting up the lung vision, and second to any challenges with different locations and how that affects it?
No, it's not really that. You just have to make sure that the board is centered where you need it to sort of be centered, and that's really it. The setup actually is very easy. As long as the patient's on the board and the board is oriented right, and it's going to be oriented right because you draw a picture of a person on the board to make sure it's not upside down or backwards. That's it. Registration takes about 15 seconds, and then target updating, which happens at the beginning of the case, takes another 20 seconds. Each recon takes about a minute. So within 5 minutes, you're registered and ready to go, and already you're registered, and then target updated immediately. And then when you get out there, if you want, if you feel you need to, you could do another spin, another minute and a half, and then you're ready to go to biopsy. So the process is, right, super quick.
So yeah, to that point, ultimately, you need to have the same exact team always with you, ready to go and trained. And they will have the patient ready for you within a couple of minutes. The floor tech that's working with you, unless you're controlling the floor yourself, depend on which room you're using or whether you're in the C-arm is fixed or not. But ultimately, just always have the same team. So it's a well-oiled machine. So you're not re-explaining the process to every single different tech and different respiratory therapist and nurse. So I always, well, my model is very different, but I have exactly the same person.
I can agree with that. Again, I work at a hospital where I don't have a choice. I have to work with whoever they give me, and there is a big difference. So the rad techs matter a lot.
Absolutely.
Their understanding it. Anesthesia matters a lot. The idea of having to explain what APL is every single time, like doing a breath hold every single time.
Yeah.
That's going to be what is the hardest part that takes the most time for your cases is when you have a bunch of new people each time you do it. So if you do have a dedicated team that can get trained in, or at least some super users, the difference in time for me for doing registration can be between 3 minutes and 20 minutes, depending on who's in the room. So
Yeah, that's long. I would lose my mind. All right. You know, visit the booth. They'll show you a little bit more of the technology, but thanks everybody for coming.
Thank you.